Okay, so hello and good evening, everyone. Can you please let me know in the chat box if my audio and video is good? Just waiting for your comments so that I can start the session. Okay, good evening, Dr. Vinish, Surya, Karthik. Okay, good evening. So I think, shall we start the session? So, yes, yeah, good. So we'll start the session today. So basically, this session is a very concise and crisp discussion of the 10 MCQs that were asked in the Monday midday quiz, a series of quizzes that we are doing in the DocTutorials app every Monday, 9 p.m. So just a short quiz of 10 MCQs to be solved in 5 minutes, immediately followed by a discussion. So this time the topic was seizures and epilepsy. So we'll be having a quick discussion of these MCQs. I'm not going for a very elaborate discussion, but along with the discussion, I'll try to give you maybe one additional extra point related to the question, so that even if you have done well in the MCQ exam, you get something out of this discussion as well. Okay, so I want all of you to listen to this clearly, and I want everyone to be active in the chat box while I ask you a question, so that we'll make it an interactive session. Okay, right. So let's see it question by question. Okay, and I'm extremely happy, I should say, seeing the performances of the students. See, every exam I try to put 5 or 6 easy questions, but maybe 2 or 3 questions will be slightly on the tougher side. And I can see so many students performing exceedingly well, and from different parts of the country. And I think as a teacher, it is again a good sight to see such good performance by my dear students. Okay. Now, let's start the quick discussion. Right. Question number 1. Okay. Now, listen to me. What you should be listening to while I discuss these questions is not just the answer. Just see the way how I'm approaching these MCQs and watch out for the additional points that I give you during this discussion. Okay. Question number 1. A 6-year-old boy. Always age is very important. 6-year-old boy is evaluated for what? Attention deficit. So it's not for any seizure per se that he has come to the doctor. It is for an attention deficit. And his parents were told that he is inattentive at school and appears to be daydreaming. Okay, appears to daydream and not hear what the teacher is saying. The child has a normal birth and development history. Neurological examination is normal. Now, the EEG reveals a 3 hertz generalized spike and wave discharge. Now, if you read the first half of the long stem question, it is saying about some attention problems and he is daydreaming in class. But it is the second part of the question which actually tells you this is probably related to an epilepsy syndrome. And the most important clue here, in addition to the daydreaming, which is obviously there in the history, and you know that in terms of seizures, the absent seizures very commonly present with the complaints of daydreaming, right? Absent seizures. Now, this EEG finding is also very important when you get a 3 hertz spike and wave discharge. What does a 3 hertz spike and wave discharge mean? In 1 second, there are 3 spike and wave. A spike would look like this and a wave would look like this. So in 1 second reading of EEG, if there are 3 spike and wave patterns, that is called a 3 hertz spike and wave pattern. So there is a generalized spike and wave discharges happening. And another important MCQ point is that the EEG finding is often triggered by hyperventilation. So as you record the EEG of a patient, if you ask the child to hyperventilate, this can trigger the episode both clinically as well as in the EEG. So absent seizures is what we have understood or we have derived from this case. Now, absent seizures can be a part of different epilepsy syndromes, but considering the age of the patient, 6-year-old boy with absent seizures, because 3 hertz spike and wave pattern is classically associated with absent seizures. And can you tell me what is the diagnosis here? What is a complete diagnosis here? This is that of a childhood absence epilepsy. Childhood absence epilepsy is the condition that presents in the age group of around 4 to 8 years, 4 to 8 years. Sometimes even you can say up to 10 years as well, with typical absent seizures. And EEG showing this finding. And what is going to be the drug of choice? Again, very important. Now, the drug of choice for childhood absence epilepsy, among the options, no doubt it is ethosuximide. Now, the extra point that I want to discuss with my students here is that I have seen many students asking this doubt, sir. I have been taught in one particular coaching institute that valproate is to be given, another particular coaching institute that ethosuximide. See, please don't have any confusions. I am myself a neurologist, and let me tell you what is most authentic about this. See, this screenshot that I'm sharing with you is from the Bradley textbook of neurology, the latest edition. And that is the world standard textbook of neurology that is followed at DM level, anywhere. So you look at this. If a patient is having a absent seizure, if the question is asking about the pure generalized absent seizures, as can occur in childhood absence epilepsy, no doubt the drug of choice is going to be ethosuximide. Now, remember, ethosuximide was previously not available in India, but now it is available in India and it is the drug of choice, no doubt. Now, what are the other drugs that can be given in case of childhood absence epilepsy? Is it just ethosuximide? No, you can also give drugs like valproate and lamotrigine. So valproate and lamotrigine can be given, but as you can see in this line, for pure generalized absence seizures, ethosuximide is the first drug of choice based on comparative trial with valproate and lamotrigine. All three can be used, best is ethosuximide. But in what scenario should you choose valproate? Number one scenario, if ethosuximide is not in the options, okay, then you can choose valproate. Otherwise, see, you can have a patient who is having absent seizures, and along with that, he is having a generalized seizures as well. So patient is having a combination of seizures. In this case, where he is having multiple seizure types, here you will have to pick valproate. Okay, because if the history says it's not just absent seizures, patient is also having some generalized tonic-clonic seizure episodes as well, then you will have to pick up valproate. Okay, so that is what additional seizure types, it is valproate. And not just that, if the patient is having atypical absent seizure, typical absent seizures, ethosuximide. Atypical absent seizures, it is valproate. Okay, so if the question mentions either atypical absent seizure or absent seizure plus another seizure type or ethosuximide not in the options, these scenarios, please choose valproate. Okay, right. So that you should know. Okay, so Krishna, usually hyperventilation precipitates absent seizures and not other seizure types. Okay, so when there is an absent seizure, there is carbon dioxide washout, which can often trigger the absent seizures. Please understand that. Perfect. So I hope we are clear regarding that and there is no confusion here. Question number 2 is a factual question. Now, remember in your entrance exams, whether it be NEET, PG or INICT, the topic of anti-epileptics is very important and often it is asked, in a linked fashion with medicine. Okay, they might give you a clinical scenario with a side effect of an anti-epileptic, and sometimes you can get a factual question based on this anti-epileptic. Now, the question here is, what is the recommended therapeutic serum concentration of phenytoin? Answer is 10 to 20 milligram per liter. But I'm going to give you one additional point in this discussion. Now, read the question carefully. If the question is the recommended therapeutic serum concentration of phenytoin, answer is 10 milligram per liter to 20 milligram per liter. No doubt about it. But remember, if the question says this protein-free recommended therapeutic serum concentration, okay, protein-free recommended therapeutic serum concentration, that is 1 mg per liter to 2 mg per liter. So sometimes you can have both these options. So watch out whether they are mentioning about phenytoin or just protein-free fraction of it. So according to that, the answer can actually vary. Here, no doubt, it is 10 to 20 milligram per liter. Third question, I think this should be the easiest question in this paper, right? What is the first drug to be given in the management of status epilepticus? Yes, phenytoin, levetiracetam, sodium valproate, all are drugs that can be given in the management of status epilepticus. But always remember, a faster acting drug should be given first. You give something that acts fast first. And what is that? Benzodiazepine. And among the benzodiazepine, the preferred one is lorazepam, which can be given IV. Okay, but also remember, sometimes if you don't have lorazepam IV in the options, what are the other options that you should be looking for, which can also be given as first line agents? You please watch out whether diazepam is there. You also watch out whether midazolam is there. So not only lorazepam, you can also give, also not all together, but either lorazepam or diazepam or midazolam. The doses I have taught in detail in my lectures in the app. But remember, among all these, the preferred one is lorazepam. In addition to this, you can even give the, the latest research also supports using midazolam nasal spray and also diazepam rectal gel, which can also be given in scenarios where, you are somewhere very far from hospital and, you have got to give something. Think of giving a midazolam nasal spray or a rectal gel of diazepam. Okay, right. Question number 4. Based on the MRI abnormality, what is the likely peculiar seizure type? Now, interesting question. They're asking about a peculiar seizure type in this patient. Now, you watch out, look at this MRI. Can somebody tell me what is the abnormality that you're seeing here? Can somebody tell me what is the abnormality that you're seeing here? So if you look at this MRI, a close look will show an abnormality in this region. Are you seeing a lesion here? Are you seeing a lesion here? Yes or no? Are you seeing a lesion here? Okay. So there is a lesion there. And what is that region? I can just again show you, just a diagrammatic representation as well. Can you see a pathologic lesion here? Okay. What is the lesion that is likely, be present there and can cause a peculiar type of seizure? Now, this is what is referred to as hypothalamic hamartoma. Do you think this is a tough question? Well, the image might look apparently a bit tough, but remember, this is a previous NEET PG question where they have given a factual question. That is, gelastic seizures. What did they ask? Gelastic seizures are associated with. Now, at least some of you will be wondering, sir, what is this gelastic seizure? Gelastic seizures refers to laughing associated seizures. Laughing associated seizures, which means you look at the child, when he develops a seizure, you might think that he is having an outburst laughter. He's laughing, but actually it is a type of seizure. It's called a gelastic seizure or a laughing associated seizure, which can happen with hypothalamic lesions, that is hypothalamic hamartoma, which is also known as diencephalic or tuber cinereum hamartoma. And this is a non-neoplastic congenital malformation, which is associated with precocious puberty, behavioral disturbances, and also gelastic seizures. Remember, this is a previous NEET PG question. Maybe at least some of you would have found a bit difficult in identifying the lesion here. That is okay, but remember, this was asked. And you know that, look at the other options. So this is gelastic seizures. Myoclonic seizure types. Can you tell me one epilepsy syndrome associated with this? JME, that is juvenile myoclonic seizures. Salam seizures, can you tell me which condition is associated with Salam seizures or infantile spasms? It is the West syndrome. And absence seizures classically associated with childhood absence epilepsy. Here it is gelastic seizures associated with hypothalamic hamartoma. Question number 5, pathologic myoclonus may be associated with. Remember, there are two types of myoclonus, pathologic myoclonus as well as physiologic myoclonus. So remember, physiologic myoclonus is that jerk, at least, most of you would have experienced some time or the other, when you go to sleep, you get that sudden jerk, no? So that is a physiologic myoclonus. They're asking about pathologic myoclonus. Pathologic myoclonus can happen in different conditions. So let me just tell you what are the conditions where you get this pathologic myoclonus. So one condition is anoxic brain injury. Yes. when suppose a patient is going to a condition where there is a reduced blood supply to the brain. For example, he has gone to a cardiac arrest. Okay, so he has landed up in a cardiac arrest and there is a decreased perfusion of the brain. This can result in some sort of hypoxia or anoxia, which can result in a brain injury that can cause a pathologic myoclonus. Metabolic disorders, for example, if a patient is having uremic encephalopathy, if he is having hepatic encephalopathy, that can result in myoclonus. Degenerative CNS disorders like Creutzfeldt-Jakob disease can also result in myoclonus. So these are the conditions that can result in myoclonus. So answer is all the above. Okay, right. Question number 6. Most common syndrome associated with focal seizure with impaired awareness. So you know that focal seizures are of two types: focal seizure with preserved awareness and focal seizure with impaired awareness. So the question is, what is the most common epilepsy syndrome associated with focal seizure with impaired awareness? Now, remember, focal seizure with impaired awareness can be due to many causes. But if they're asking about the epilepsy syndrome, where this is the most common seizure type, the answer is what? The answer is, this is also a previous NEET PG question. It is mesial temporal lobe epilepsy. Mesial matlab what? It is a medial part of the temporal lobe. There is some sort of a pathology. And what is that pathology? There is a hippocampal sclerosis. So the medial part of the temporal lobe, hippocampal sclerosis is there. And that is what results in this mesial temporal lobe epilepsy, which can result in a type of focal seizure with impaired awareness. Understood? Okay. So that is the most common syndrome. Okay. Next is, which of the following can be a manifestation of focal seizure? Now, whenever I have taught, the seizures and epilepsy to you, I have always emphasized the importance of understanding the classification of seizures according to the International League Against Epilepsy. Okay. Just the organization name, no big deal, but it is very important for your exams. I have told you that focal seizures is of two types, with preserved awareness and impaired awareness. Now look at this, which I have discussed in my lectures. Whether it be focal seizure or generalized seizure can have either a motor onset or non-motor onset. So remember, all seizure is not just motor activity. You can even have non-motor seizures. So talking about focal seizures, motor matlab you can have a convulsion, correct? But what about non-motor? You can even have autonomic manifestations. Yes. So convulsions can be there. You can have paresthesias, especially if it is involving the parietal lobe. Okay, focal seizure involving parietal lobe can produce paresthesia. And you can have focal seizures producing autonomic features as well. So you can have sensory manifestations, autonomic manifestations. So basically, why I was putting this question is only to test your knowledge on the non-motor manifestations that can accompany a seizure as well. What is meant by convulsion? Convulsion means motor manifestation of a seizure. So all the tonic movement, clonic movement, these are all convulsions. Okay. So what about the non-motor activity in case of generalized seizures? Example is the absent seizure. Absent seizure is a type of generalized non-motor type of seizure. Okay, right. That is question number 7. So the answer is any of the above. Okay. Question number 8. My question is regarding a new anti-epileptic, especially in INICT exams and also in NEET PG exams. They do test your knowledge on newer drugs. Everyone knows about the conventional anti-epileptics, but this is one newer anti-epileptic that you should be aware of. It's not so new. It has been there for a few years now. So that is cannabidiol. It is FDA approved for which condition? Remember, every question with all of the above, I am sure that you would be tempted to mark all of the above. At least some of you would have marked. But the answer for here, for this question is Lennox-Gastaut syndrome, or LGS. Okay, LGS. Now, I want to see your answer in the comment section. What is usually the first line anti-epileptic given for Lennox-Gastaut syndrome? This is a previous question. Let me see how many of you are answering. What is the usual first line agent given for Lennox-Gastaut syndrome? As you answer, I will just go to the discussion and come back. So basically, cannabidiol has been FDA approved for two important epilepsy syndromes. The one which you all should know is Lennox-Gastaut syndrome. Second one, maybe, even if you do not know that, that is fine. There is another epilepsy syndrome known as Dravet syndrome. But Lennox-Gastaut syndrome is important for NEET PG and INICT exams. Okay, so you can give cannabidiol, which is available as an oral solution. So at least, some of you will be wondering, sir, when you use this drug, won't it have any sort of psychoactive properties when you use a cannabidiol? Remember, this cannabidiol, this anti-epileptic, does not interact with the cannabinoid receptor CB1, and hence It is not having the psychoactive properties of hydrocannabidiol, which makes it a safe drug. Okay, so that is why you can use this drug for Lennox-Gastaut syndrome. And I can see in the comment section, Krishna, Reshma, Ahana, Pratusha, Vinish, Tejaswi, and Yasmin, Lakshmi, all of you are correctly answering yes. Usually, the first line drug that is given for LGS is the sodium valproate. So you can give sodium valproate as the first line drug. Now, let me ask you another question. Which other anti-epileptic can be given in this condition, Lennox-Gastaut syndrome, which is also, a drug that is used in the migraine prophylaxis? Obviously, sodium valproate is also given for migraine prophylaxis, but what is another drug that can be given for migraine prophylaxis, but can be given in Lennox-Gastaut as well? Answer is topiramate. Topiramate. Okay, so that is also a potential question that can also be given. Another anti-epileptic drug that can be given in Lennox-Gastaut syndrome is rufinamide. But the first line drug is always sodium valproate, though you can use drugs which I just mentioned as well. Question number 9, as per the latest ILAE classification of seizures, myoclonic seizures is categorized as only someone who is, who has gone through the classification well will be able to answer this, in a solid fashion. Remember, according to the ILAE classification of the seizures, you have got focal and generalized. Okay. Now, previously, what happened was, previously in the old ILAE classification, the myoclonic seizures were only categorized as generalized. That means somebody only could have a generalized myoclonus. But if you go through this classification now, you can see that both in focal and in generalized, in the motor manifestation, you can have myoclonic seizures. So there can be a focal myoclonus, there can be a generalized myoclonus. So remember, according to the latest ILAE classification, you can have myoclonic seizures either as focal onset or generalized onset. Perfect? Yes. Right. So it's very important to know the classification, right? Now, all the following drugs are commonly used in the management of status epilepticus except lacosamide, phenytoin, fosphenytoin, carbamazepine. What is going to be the answer here? At least some students immediately after the exam, they message me, sir, I got this question wrong. I thought it is lacosamide. See, I agree. Phenytoin and fosphenytoin, most of you know, it is used in the management of status epilepticus. Lacosamide, some years before it was not used, but now lacosamide is used in the management of status epilepticus. It can be used. But what is the problem with carbamazepine? Carbamazepine cannot be used in the management of status epilepticus. Any particular reason why? Is it that the effectiveness is not that great? The only reason is because carbamazepine does not have a parenteral preparation. Carbamazepine, except for research purposes where you've got a solvent and you can use it as an injection, in common routine clinical practice you are not going to get any injection of carbamazepine. Why no injection? Because till date we do not have a definite solvent for carbamazepine. Okay, that is why you are not having injection preparations. But for your knowledge, I am saying in research purposes there is a solvent, but otherwise it is not there. So carbamazepine is the answer here. Okay, so I think this exam was relatively on the easier side, but a few, at least 2 questions I have put slightly tougher. So I hope all of you have given the exam well. But let me just remind you, take another 2 minutes more. See, in DocTutorials, from today we are having the NEET PG 24 students, those who are attending the NEET PG 2024, and also to others. It's open for everyone, whether you are a subscriber or not. There is a 2020 series that has started today. And what is the first exam? Medicine. Okay, so you will have 20 tests all in all, which means 19 subjects, 19 exams. The detailed timetable is there in the DocTutorials Instagram page. Okay, and 19 subject tests and the grant test will be there. And per exam, you will have 20 minutes. Okay, so per exam, 20 questions in 20 minutes. So today from 7 p.m., the first exam is medicine. I want every one of you to give. Even if you're attending the current NEET PG or not, see, exams are always going to help you assess. Now, I'm sure you see this, Monday midday. You see there are a lot of students who have got 40 out of 40. There are a lot of students who have got 35. Now, even if you're a student who has not performed well, it should not demoralize you. It should tell you that, oh, others are studying, I should also study. It should give you a positive motivation and never a demoralize. It should never demoralize you. Always remember in life, even if you go down, you have always got an opportunity to come back. So I want my students not to fear any exam. Now you should write the exam and try to see where you are standing. So tomorrow, 8 p.m., you will have the discussion of this. So look at this. Today from 7 p.m., the exam is live, just 20 questions. And this 20 questions, I have selected based on the NEET PG 2023 question paper. My recall video is available in the YouTube. Just type NEET PG 2023, Dr. Rahul Rajeev, DocTutorials. You can see a recall video. Have I put the exact question from that recall video? No. I have just selected the topic and I've asked you a different question from the same topic. It's just to, tell you the importance of previous year topics, and I want you to learn that topic thoroughly. So today from 7 p.m., it is live for 24 hours. It is live for 24 hours, which means till tomorrow 7 p.m., you can take the exam. You will get an All India ranking as well. So you please write this, just 20 questions to be answered in 20 minutes, and I will see you tomorrow once again. How many of you are there who are going to join me tomorrow, 8 p.m. in this YouTube channel? 20 very important questions will be discussed. And as I said, I'll try to give you a couple of additional points as well. And it's not just about the exam that is, coming, that is ongoing today. After that, you will have surgery, orthopedics, lot of exams, short exams, mini exams, but focusing on most high yield content. Attend all these exams conducted by DocTutorials and also watch the YouTube discussion videos, which will be very productive, because it's again going to be a very short discussion video. I'm not going to take a very lengthy discussion, short and crisp. That is what I'm going to do. And I want all my children to attend the discussion and make best use of it. So Shubham, thank you so much. Yes, I'm also waiting for the discussion tomorrow. So I hope all of you are doing good. Mithilesh, Shubham, Tejasvi, Ravi, Kavi, yeah, Krishna. So see you all tomorrow, and keep yourself happy and healthy, and God bless you all. Thank you so much. See you tomorrow at 8 p.m.